And good morning, everyone, from the St. Louis, Missouri, and the home of the Missouri Institute of Mental Health. My name is Tom Pansella with the Missouri Institute of Mental Health, and I'd like to welcome you to this morning's program on using FACIT for COSP Continuous Quality Improvement. I'm going to introduce our lead speaker to you in just a moment, and she'll introduce the panelists following her presentation. But I wanted to give you an opportunity to note that if you were interested in purchasing CEUs for today's program, just look right under the video window. You'll see a link for purchasing the CEUs. If you'd like to pop up the slides in a separate as a separate window, you can do that by clicking the slides in PDF format link. That'll pop them in a separate window. You can follow them on your own. There's also a link below that to purchase or get further information on our upcoming DSM-5 training programs. So now I'd like to introduce my colleague, Dr. Jean Campbell. She's a research professor here at the Missouri Institute of Mental Health, which is part of the University of Missouri St. Louis, and she's an internationally known mental health consumer researcher, speaker, and consultant, and she's the director of our program in consumer studies and training. Throughout her career, she's been a forerunner in the effort to define the recovery and well-being of recipients of mental health services in research and to promote multi-stakeholder approaches in evaluation and service delivery. She's best known for her role as the principal investigator of the MIMH Coordinating Center for the Consumer Operated Services Program's Multisite Research Initiative, the largest and most rigorous study of peer-run programs in history. She's written over 40 articles and reports on the development and use of management information systems since system improvement, shared decision-making, privacy of health records, and peer support programs. She's best known for her groundbreaking consumer-directed research study of mental health consumer well-being in California, the Well-Being Project from 1989, and the supplemental award-winning documentary, People Say I'm Crazy. Dr. Campbell's received many awards for her work as a distinguished researcher and mental health consumer advocate and has been recognized as a leader in promoting recovery-based mental health system. Dr. Campbell, the floor is yours.
To this webinar about using the FACIT for COSP Continuous Quality Improvement. I am flattered with that long introduction, and I would like to add, though, that I am also a mental health consumer. I think that that's important. And the second thing is I will be retiring shortly and look forward to passing the torch, and this webinar is one of the ways that I am passing the torch on consumers being involved in evaluation. In fact, we're concluding today a 4.5-day training of the peer evaluator teams here in Missouri, which are the consumers who are evaluating consumer-operated service programs here in Missouri in order to help them become evidence-based practices. You know, I think back to 1998 when we began the COSP Multisite Research Initiative to really evaluate what are the outcomes of peer-run programs, which we call consumer-operated service programs. And as you heard, that was the most rigorous study ever done of these peer-run programs. 1,827 participants in consumer-operated service programs were involved in the study. Also, implementing the study, it was a collaboration of professional researchers, also consumer researchers, and peer providers. During the study, we discovered that the practices in the consumer-operated service programs really led to the production of well-being, which we found in COSP could be defined as hope and the hope of recovery, self-efficacy, empowerment, goal attainment. These were critical aspects of COSP well-being. And through the practices, which we call the common ingredients of COSP, we have transformed the consumer-operated programs over the last 5 years into, I would say, near-perfect evidence-based practices. They certainly have moved from a mom-and-pop recreational peer support program to one that really has a mission of recovery and people gaining an empowered life in the community. When the results of the multi-site study were reported, SAMHSA identified COSP as evidence-based practices, and a subsequent toolkit was published and distributed throughout the United States. However, we still got pushback within the consumer provider community and advocacy community that, well, the evidence-based practices aren't being really done in this program or that program, and maybe those sites that were involved in the study were good, but our programs aren't like that. And so I had the great opportunity here in Missouri to begin a 5-year field practice of the fidelity assessment of the COSP programs, and to make sure that they were delivering the common ingredients, which would lead to the well-being outcomes. And over the last 2 years, we have paused to change the protocol and improve it, and also begin to look at the quality improvement plans for the COSP providers. Because all of them have a quality improvement plan, but it's clear that we need to do more technical assistance for quality improvement. And that is why we have developed this webinar and are really focusing on how you can use the FACIT results to become an evidence-based practice. So now I'm going to begin to talk about continuous quality improvement, which is the method that works best within a peer environment with some modifications, because continuous quality improvement was developed within an industrial culture and then moved to large healthcare organizations. But the components of continuous quality improvement work quite well with our FACIT evaluations and the implementation of them. So we're going to begin our story sort of midstream after the evaluation is done, and the peer evaluators here in Missouri have identified the evidence of the common ingredients, and they have scored the programs. They turn those in to a group of 3, the 2 peer evaluators and a peer services program specialist that works for DMH, and they write a report and turn that over to the COSP, or the Consumer Operated Service Program. So what happens at that point is what we're going to talk about today. So we ready for the slides? Using the FACIT for cost continuous quality improvement. So in this webinar, we're going to discuss how to use the FACIT for cost continuous quality improvement. First of all, there are basic principles of continuous quality improvement, or what I might refer to as CQI, for use in our COSP. We're going to explain how to facilitate collaborative CQI processes so that CQI can enable transformation of cost to evidence-based practices. We're going to illustrate how to analyze the Fidelity Assessment Common Ingredients tool scores that the programs will receive as a report to produce the charts and bar graphs of the common ingredients. And then finally, we're going to have a panel with cost providers who have field experience using the FACIT for continuous quality improvement in our COSP here in Missouri. So first of all, let's start off with a definition. What does continuous quality at its core really mean? Well, it means that every person in the organization, in this case the COSP, actively participates in the continuous improvement of the processes and performances to ensure customers, in this case we call them members or participants, are satisfied with the program and the services and supports they receive. It really means doing the right things, doing them well, and satisfying the members in the COSP. So as your COSP develops its CQI efforts through the FACIT, outcome evaluations, and consumer satisfaction assessments, these become invaluable assets for developing an evidence-based practice that's truly responsive to mental health consumer needs and interests. As the COSP members' familiarity with continuous quality improvement principles grow, you may wonder how the COSP ever operated without these evaluation tools in place. So evaluating your COSP, let's define the Fidelity Assessment Common Ingredients tool, which provides the information about the assessment in order to determine for a consumer-operated service program how well it faithfully implements evidence-based peer practices according to the COSP Common Ingredients structure, values, and processes. I think I actually need water. I have excuse me out there, I have a little tickle in my throat. So the COSP Common Ingredients include the 46 common ingredients items that define the COS evidence-based peer practices. Details of the common ingredients can be found in the COS Evidence-based Practices KIT, which is available online at SAMHSA.gov. Peer staff training modules in the Evidence-Based Practice Toolkit are organized around the 6 common ingredients domains. That includes the operations, the environment, the values, the belief system, peer support, education, and advocacy. Continuous quality improvement and performance excellence. What does it have to do with you? You as an individual, because one of the most important things is to have a culture of continuous quality improvement, and every person needs to own that culture and feel part of it. So think about a time when you wanted to improve your performance. What are the motivators for undertaking a new regimen in quest for your personal excellence? Think about those. Maybe you wanted, you thought that if you improved your excellence that you'd have a better quality of life. That's a tremendous motivator. A higher level of self-esteem, higher levels of personal mastery. And you overcome the fear of the status quo or how things operate as they are right now. You look forward to change in the future. Those are all personal motivators that can be built into your culture. I love this phrase, be the change you want to see. That comes from Gandhi. And it really is important in implementing a continuous quality improvement program. In our programs, we start off with the peer values. So it isn't too hard because the 46 common ingredients are the ingredients that are common to most consumer-operated programs, and grew organically from the 30 years plus that peer support programs have developed and matured and spread throughout the United States. So you take peer values and you take continuous quality improvement, and what you end up with as the individual is COSP quality. You're turning your values and beliefs into COSP quality improvement. So what does continuous quality improvement mean? As you can see, it means plan, do, study, act, change. Those are the major steps. And as I said, we've started here in midstream with the study part, has already concluded. What happens, what does the program do with the results? How does leadership, because leadership is a key factor in a continuous quality improvement program bringing COSP to an evidence-based practice. How does leadership drive this process? Well, one is leadership has to be able to manage the facts. They have to manage with facts. They have to drive out fear of facts, fear of continuous quality improvement. They have to provide the leadership to enable those participants and members of COS to embrace improvement and embrace the evaluation. They have to follow the Socratic method, which means that you arrive at a consensus through asking questions. And you have to promote the use of comparisons, and you have to stretch goals. Comparisons between this program. In your programs, you have to compare between 1 year and the next, between groups of people that attend your program. And you have to be able to stretch the goals that you now have to become greater than what you are. And you have to fix the processes, not the people. And focus on the peer culture. CQI principles are really all about establishing a culture including vision, mission, and value statements that demonstrate a commitment to quality care and services. Providing the leadership and support to guide, facilitate, and involve staff in quality improvement through teamwork and participation. Managing and improving processes so intended results are achieved. And meeting and exceeding the needs of customers, which again we call participants or members. And what's the only way to be able to do that is you have to ask the peers who attend the program what they want, what are their needs, what are their wants, what are their goals, because everyone's recovery journey is unique. But fortunately, we operate in a peer environment. So we already have a relationship between our principles, our values, and we collaborate with our skills and what we call our peer practices. And what we need to improve is our decision-making process for improvement. And as you can see, the customer, as again we call our participant or our member, is in the middle of that dynamic. CQI is a team approach. Continuous quality improvement's premise is that teams are better able than individuals to analyze processes fully. The main feature of the CQI team approach are support from management, staff involvement, and COSP member engagement. That is a team. So when that report comes to the COSP, these people have to be engaged as a team. And what we recommend is that you actually, the programs establish a continuous quality improvement team that's composed of members from these different groups to help implement the process and move it along. Also, continuous quality improvement involves a scientific approach. The importance of data to CQI is to provide a sound basis for decisions. And I have to say the Fidelity Assessment Common Ingredients tool is soundly based on the scientific principles. And if you had gone through the 4.5-day training with our peer evaluator team wannabes, because they're not certified until they pass an exam today, you would realize how rigorous the training is and how hard we have worked to eliminate all sorts of variation that could be attributed to how the questions are asked or how the questions are analyzed. We have taken a rigorous scientific approach. Just like our multi-site was one of the most rigorous studies ever done of consumer-operated programs, a randomized controlled trial, our fidelity assessment is also rigorous, and how we implement it is rigorous. And now we're talking about how to implement the results of all that effort. One is the scientific approach within continuous quality improvement, which involves data analysis at the program level, systems thinking at the program level, and benchmarking at the program level. So the types of data that are used within a COSP are, I would say, number one, the FACIT scores. But we're encouraging COSP to also begin, as they begin their continuous quality improvement journey, to also begin to collect, and some of them already do, consumer satisfaction data. Demographics. So who do they serve? And are the common ingredients provided to everyone? Or are people of color or homeless people or elderly people getting a disproportionate amount of common ingredients? So some people might be getting more than others. So it's important to collect demographics. Also encounter data. Encounter data is what we call here our duplicated count, how many people come each month, every single visit, the number of visits, and an unduplicated account, which means how many actual people come. And then we also keep track of the activities, that the number of people that attend certain activities. That data is also important. And finally, the budget. What are your resources? That's data or information that's important. That can be used in conjunction with the FACIT scores to develop a continuous quality improvement plan. So what's systems thinking? Well, a systems approach, besides we've already talked about the scientific approach, the systems approach is also important. Everything is interrelated. It's important to think about that. So the whole always has to be considered, as well as the individual parts. If something changes in one area, it is necessary to check what is affected somewhere else. So if you make improvements in your formal peer support, you may see improvements in other parts of your program that you weren't really working on directly, but it's because of that interrelationship. Also, you have to be sensitive to cause and effect relationships. You may do something thinking it's going to make a certain change, but it doesn't. It may be that your cause and effect reasoning is flawed, and you have to go back and revisit that. Systems thinking means that even while analyzing separate parts of a process, in this case, the domains of the common ingredients, for example, if you're looking at the environment or operations or your peer processes or your belief systems or your education or your advocacy, these different parts of the process of becoming an evidence-based practice, the relationship among them, these domains, are still to be kept in mind. It also means that the system's processes are considered more likely to be the cause of problems than are individuals. We tend to look at what are the failures of the people implementing the processes we already have in place. But in CQI, we look at the processes rather than the individuals. And that very much fits into the peer principle where we look at people's strengths, not their deficits. Here is one way to think about systems thinking. Many of you may have had to develop a logic model that looks at your inputs into your program, its processes, then what are your outputs, your products, your services, your outcomes, and how those impact your customers, or in this case, your participants or members. But today we're going to talk about the CQI cycle. At the beginning, we talked about the plan, do, study, act. Which is sometimes called PDSA, which is at the heart of continuous quality improvement. You could start anywhere on this cycle. This is where the literature starts, so we'll just follow that. But you can start anywhere on this circle. It's all intertwined. So starting with plan, your programs at the COSP would identify your purpose and your goals. Or and most of our programs have already gone through that process and have that in their mission statements and on their brochures. In fact, that's one of the things that's one of the common ingredients that it's incorporated in the belief systems, and our peer evaluators identify that. But it's good to revisit that when your program members and your staff and your administration, your leaders, are incorporating the FACIT report, is to identify, revisit your purpose and your goals. And also begin to develop a theory of how your program operates. Also define how you will measure your successes. You don't need to wait a year to see if there's a change in the FACIT scores. If one of your goals is to increase vets coming to your COSP, well, one of the ways that you would measure that is by looking at your encounter data. How many vets actually you can count them? How many come in? Maybe look at the consumer satisfaction of vets in your center to see how well you're serving them. So you have to come up with ways to be able, over the year, to measure the success. Have a plan. And then finally, you need to plan out your activities. What are you going to do? When are you going to do it? When are the milestones going to be reached that you have set those goals? That is the beginning of the PDSA cycle. Then there's the doing, executing your plan, undertaking the activities, introducing the interventions or the changes, applying best knowledge to the pursuit of your desired purpose and goals. PD. Then we go to S. Well, that's where the FACIT comes in. And annually here in Missouri, for the last 5 years, we have had each of the COSP evaluated for evidence of the common ingredients. So we have measured, we have tested our theory of our plan, we have measured our fidelity, we have studied the results for progress and success or unexpected things that have happened over the year. And we look for lessons learned or problems solved. Looking at that longitudinally from year to year begins to provide that information. And then we act. We integrate the lessons learned from our study. We adjust our methods. We identify what more we need to learn. And then the cycle begins again with the planning. So let's talk a little bit about CQI in practice. So let's say that a COSP has gotten their FACIT report, and through dialogue with their members and their staff and their leadership, they decide that one of the things that's a problem is that a new peer program that they have set up in their COS is not being used at capacity. It could be a RAP, peer support group, or even the example I gave, a program for vets, a women's group. It could be almost anything, but it might have been built, but people are not coming. It's not being used to capacity. It's not achieving the goals that have been set for that program. So what we decide to do, maybe our plan, is to increase provider referrals. We want, using the vet example, maybe we want the VA and places that serve vets to really begin to send us referrals, because we believe we have a program here that really is unique and hasn't been met within the veterans community. So what do? We have our plan. We want to increase referrals. We've identified what the problem is. We have the plan. What do? Well, we could visit provider offices to explain the program and referral process. We can create and distribute easy-to-use referral form for the providers in the community. We can send program brochures to provider offices and send them frequently, refresh them. And we can attend provider staff meetings every 3 months, for example, to increase awareness of the program. So that is the actions that the program takes. The checking, or the study. We monitor referrals on a monthly basis by provider. And we analyze the effect of all of our strategies by the number of referrals received. We also, on an annual basis, will get the FACIT results as well. But I have already talked about how other data also can work with the FACIT. And then we can take action. We can continue in this example to practice these strategies with the greatest effect and create new strategies by using a scientific approach and systems thinking and applying leadership. I want to spend a little bit of time acquainting people. So you're saying, well, what does this FACIT report actually look like, and what does the study really look at? We have created, as an outgrowth of the multi-site COSP Multisite Research Initiative, we created, along with the Fidelity tool, what is called the eFACIT User's Guide that's used with the eFACIT data entry program, which really records the scores that our peer evaluators give to each program on each item. And there's a score conciliation process that also goes on. But the program, this program for data entry and display was developed as a simple data entry system for FACIT scores on each of the 46 common ingredients that are entered in the FACIT score sheet. And the program automatically produces charts based on FACIT scores and benchmarks. And remember I said that COSP need to benchmark? Well, you need scores. When you're looking at your FACIT scores and when the program is interpreting what those scores mean, you really use comparison. Comparison with how you did the year before, but also what is called benchmarking. As FACIT spread throughout the United States, and all states utilize this system to help COSPs become evidence-based practices. We will have a really great benchmark, which is the average of all the programs, where they're at right now. So you can see overall how things are improving, and I like to use the word near perfect. We never expect it to be a golden COSP. There are also new things that will come on the horizon, new demands, new expectations, culture changes over time. But what we used in the beginning and continue to use in this application as a benchmark is the average of the 8 COSP programs that participated in the multi-site study. We believe that was an appropriate benchmark because all of these have been vetted by federal review teams and experts from the field as representing COSP, and they met the federal definition of what a consumer-operated service program is. So we provide, as part of the data entry program, this benchmark. But as the reports come in year by year, programs will also be able to compare from year to year. Compare both each of the 46 items and then the sum of the items in the domains. Compare domain to domain. And continue to also compare with the national benchmark. So here I've described what this tool looks like from the worksheet, which consists of cells that are organized in columns and rows. It's very simple. It's an Excel program. And there are tabs at the bottom of the screen that identify the names of the different worksheets. The FACIT Excel workbook contains 3 worksheets. One is the national benchmark worksheet. One is the COSP worksheet. And then the COS chart worksheet. There's a column for the range of the score. We score from 1 to 5 or 1 to 4 for each of the 46 common ingredients. For example, under the structured domain, the first item scores board participation. And there's an anchored score from 1 to 5, 1 being no member of the board is self-identified as a consumer, to 5, which means 90 to 100% of the board are self-identified as consumers. And here, hopefully you can make this out, but this is an example of the National Benchmark Worksheet, how it appears on your screen, with a column entitled Averages. Average FACIT scores of the 8 COS sites included the COS Multisite study. We've gone over that, and the benchmark is used for comparison with the score your COS receives for each common ingredients item in the 6 common ingredients domains. So the COSP worksheet is where the data is entered. And once open, you'll see each of the 6 domains with the FACIT items for each of the domains. And the charts are next to each of these domains, and they will automatically reflect the number that is entered. And here is an example of that. In the structure domain, which is one of the 6 domains, we have these items going along the bottom, and the scores from 1 to 5 or 1 to 4 going along the top in yellow for the COSP, and then you'll see the benchmark in the striped column. And these appear automatically as the data is entered. So then the last tab is the comparison of the domain scores with the national benchmark. And as I said, these charts are automatically produced and based on the total scores that are calculated by the worksheet for each of the 6 FACIT domains. And here they are. This is just with 1 year of the FACIT score. Over time, this program allows for up to 3 years, and then you continue with a new sheet. So here we have structure, environment, belief systems, peer support, education, and advocacy, the domains. And you can see that how the programs begin, they're close to what the national benchmark is. But I like to see that they're not at the benchmark, because I like the idea of programs working on improving and having a goal, and this is able to track that process. So the first fidelity assessment, which is what you've seen, establishes the program baseline and is the starting point to become an evidence-based practice. It helps the COSP identify or confirm the existence of program strengths and weaknesses. The baseline is compared to the national FACIT benchmark, and the aggregated benchmark scores become a useful standard for gauging individual COSP performance. The peer evaluator teams will conduct yearly FACIT assessments that then can be compared to the national benchmark and then also to the COSP baseline, or the item or domain change over time. So building a continuous quality improvement culture is like building a new house. With the culture of continuous quality improvement based on the shared values and goals of the leadership, the staff, and the members. It also involves trust. We were doing a FACIT training mock FACIT yesterday, and in the focus group, people talked a lot about building trust in the program, which will extend to the CQI culture. manage by fact, embrace the data, have a participant focus, high expectations, involve everyone in the process, and use assessment and feedback. Barriers to the CQI implementation that we found within our 5-year field practice. Some of them involved poor planning, lack of commitment on the part of management, lack of resources, an unsupported organizational philosophy for change, and in many cases, poor leadership because we had not trained in continuous quality improvement. And that's why we're beginning this webinar and we'll be providing technical assistance to our programs. But in the end, the continuous quality culture includes everyone, includes you. So now I'd like to turn to the voices from the field to identify the COSP Evidence-based Practices. And I'd like to introduce my colleagues here in Missouri. And to my left is Nancy Bollinger, who's Executive Director of the Self-Help Center. And in the middle here is Sarah Earle, who's Assistant Director at the St. Louis Empowerment Center. And then at the end here is Mickey McDowell, who is the Peer Services Program Specialist at DMH. So you've had experience you've been on this journey with me, really taking something that was intended to be a scientific program in a multi-site study to measure fidelity into the field. You've all been involved in this, from the bench to the field. So I'm curious, how did your COSP distribute and discuss FACIT results up until this time?
Well, at our particular center, we'll get the scores and the charts, and I will create the reports. I'll print out the numbers and the charts, and we kind of start with the staff, and the staff look at where the scores are, and we take a minute to be happy about where we score well and be proud of what we've done. And then we start looking at the areas where we didn't score well and talking about which areas we'd like to improve in. And then we type up all those minutes and write those ideas down, and then we do the same process with our line staff, and then we do the same process with our membership. We take the scores to the membership and we say, hey, what areas are important to you? And at first they were like, why are there any low scores? We love our program. But then when we explained that we wanted to improve and do better with the whole program, they started picking areas that they wanted to see improvement and that they needed improvement in. And then we take all those reports to our board of directors. And then the board of directors looks over all the reports, and we have a consumer board, and they look at what might be budgetly feasible, and then they vote on what changes they'd like to see in the program. So that's and then we implement those changes. And then we evaluate those changes, and we continue on.
So in a way, you have been using a continuous quality improvement process, but maybe not all the elements of it in a more rigorous, systematic way.
Absolutely.
It's very similar at Self-Help Center, except we take it from, where I'll do all of the scores and the reports and everything, and then I'll share it with the main staff, the frontline staff. But then we take it to our consumer advisory board, who is very involved in our programs. So we want them to actually go in and dig a little deeper into what were the issues that we faced. And we want to celebrate the successes, but we know we can improve on those as well. So we do sit there and we look at everything. And then we'll come up with ideas, and then once we have some of the positives that how we can improve, then we take it to our membership through our monthly town hall meeting, and let them know that they can. We want to share those positives with the membership so they don't get upset. Thinking that the people came in here and were negative about it, because it's not about negativity. It's about growth and recovery and wellness. So we want to make sure that they have the um, the ability to see the positives, because even if you get a lower score, it's still a positive. You can still move forward in everything, and this really helps us to do that.
Well, thank you. And Mickey, you had several roles. You were first the program director of a COSP, and then you were hired by the state to operate within DMH in different relationships with the COSP, and now you're really going to be in charge of this whole process and pulling the report together that's going to go to the programs. And I am so excited. I mentioned before I'm retiring. I'm really going to retire. But to be able to pass the torch in Missouri and for the consumer operated service programs to really own this process and take it over for themselves without me stepping in and people feeling that it's still my program. It's no longer my program. It's the peers. They've done it. They've done it for themselves. And I'd like you to talk a little bit about that.
Great. Well, I think we've been very fortunate to be a part of this process from the very beginning. You've allowed us all to play a role of implementing this and putting it, we tested it and we did the field study and everything. So I think the ownership of the project we all have felt a lot of from the very beginning. You've allowed us all to have some of that ownership of this entire project. And we've been very fortunate to have you here to mentor us all. And just as a consumer-operated program we feel that ownership with this project, just as our members and our participants have with all of our centers. So we really appreciate that role you've given us. And I've been in several different roles. Lately, my role has been more with the QCI, with some of the programs and helping them implement their plans. And as you said, we've changed some of the processes to where we will be writing the report and giving it to the programs. Then the plan is to follow up with some technical assistance and provide them more of that technical assistance to see where they want to go with those results and with their QCI, and to provide more of that structure for them. So it's a very exciting time for us.
Well, I failed to mention early on in the introduction, but we know here in Missouri what we've done, but people out there across the United States that may be watching, there are many different kinds of COSP. In Missouri, we have 10 COSP. 5 of them are drop-in centers, and 5 of them are peer phone services, or what we call warm lines. And there's other kinds of costs, from crisis respites to benefit management to housing support, employment support. There's many kinds of costs, and the one FACIT that was developed within the multi-site study, which included both mutual support and drop-in centers. But it also works with most of the other costs, because the drop-in center is the mother of all those other programs and really incorporates all those elements in one way or another within one house. But warm lines don't quite fit in that. There is not one house, and people have different names even. There's operators and callers, and the operators may be at home or they may be in a call center, but it's a different environment. Based on the common ingredients, we developed a FACIT for warm lines. And we do a FACIT on warm lines, and they are involved in the same CQI process as well.
Yes.
So I think that that's important for people to know that. And also, Mickey, you in your previous incarnation were monitoring COSP programs, weren't you?
Yes, I did the contract monitoring directly with the COSP programs.
But and you served on a evidence-based practice committee or board at the state level?
I currently do. I sit on the evidence-based practice team, which is something really exciting that here in Missouri we have our COSP and due to the FACIT have a place at the table at that evidence-based practice team, and we're working to align what we do with our FACIT and with this evidence-based practice with the other evidence-based practices that we do throughout the state and as a department at the Department of Mental Health. So it's really exciting to see us have our place at the table, and not just that table. We have our place at other tables. And it used to be that there was maybe one or two people that knew what we did at the department, and now we have what I refer to as non-traditional advocates, because they're not individuals who are enmeshed in the COSP programs, and they're not working directly with us, but people know what we do and respect what we do and see us as a viable program. And that has come out of our transformation into the recovery domains and what we're doing because of the FACIT and helping us grow in that direction. So,
Well, thank you, Mickey. As part of writing an article about this, which our experience here in Missouri, I have interviewed most of the COSP directors about their FACIT experience. And because it helped me get perspective on what we've accomplished and what some of the issues are, and also thinking about improvements and how to bid my farewell. What sort of things should I leave with Missouri to help it continue to be successful? And I think that one of the greatest improvements that I really didn't give enough credit to the programs is when we started off at Missouri was one of the TSIG grant awardees, and so received money from SAMHSA to become recovery-based. And our state included COSP in that as an evidence-based practice. They embraced my work and my vision, and that is really where the FACIT Fidelity assessment really began, because the first step was to become not only evidence-based, but it had to be evidence of recovery. So our programs also our COSP programs had to be put under that same magnifying glass and become recovery-based. And I would say at the beginning, this was a new concept for many of the people that were running the COSP programs. There was very little in terms of signs. Common ingredients were not apparent related to an understanding and the practice of recovery. And that has really changed. That has been a significant change. Is that I would say that all of our programs are recovery-based at this point. But I was curious, beyond recognition of the importance of recovery and focusing on recovery, if you can identify any other improvements that were made to your COSP based on the FACIT.
I would say that one thing is something that's so simple that one of the questions that was asked at one time during the evaluation was about, do you see anyone here as a mentor? Okay, whenever we're in our recovery process, we look to each other as mentors, as people that can, like that flicker of hope for us. And we scored very low on that, very low. and we were disheartened, because everyone there has some quality that you could see as serving as a mentor. And so one of the things that we came up with to modify the thinking was to, at our annual award ceremony, to present a Mentor of the Year award. And this gets it out front of people. It lets them know that this person did this, and this, and wow, I see them as a mentor, but it keeps that word, and that peer togetherness and helping each other in the forefront of their minds, because people talk about it all year.
Well, it also provides documentation
Yes.
that you provide mentorship.
Yes.
The FACIT is based on a triangulation of interviews in the focus group, in other words, testimony that things exist, but also observation of what is in the COSP itself. And then the third thing is the documents that substantiate, and a fact isn't a fact. Evidence isn't evidence until it can stand on those 3 points. So not only did you make a change, but you also began to document that change, and you could have in a file the list of the awardees. You could have the program from your annual banquet in there, and so when the PET members would come and do their evaluation, they would see that. How
Yeah,
about? Oh, excuse
No,
me.
I was just going to say, the good thing is that it's the participants of our program who actually do the voting. So they're using that every year. So
Thank you. How about you, Sarah?
I guess one of the largest changes that we made came directly out of our participant FACIT review when we were distributing, and all of our participants were together, and there were some areas where we scored lower, and there wasn't really great enthusiasm about, yes, we'd like to work on this or we'd like more of this. But when it came to job readiness, our participants were like, yes, we need this. We need job readiness. If we can make a program and help with job readiness, that was something that we desperately need. And so we started developing a job readiness or job development program. We have an employment group now. We help with resumes. We help with searching for jobs. We help with interview skills. We help with interview close. It's a whole job readiness kind of program, and that's really been a great program in our center, and it's really gotten off the ground, and that came directly out of that focus group with our participants and the FACIT scores.
And how about you, Mickey?
Well, I'm fortunate enough to get to see all of the programs, and I've seen so many things added at various programs, formal programs of peer support or problem solving or crisis prevention programs that were formal that have been added in different places. Employment programs such as Sarah's have been added in places around the state. And informal programming, a time and a place. People were given more space to have more time for informal peer support as well. If there wasn't enough space or enough time, if everything was too structured. Just a lot of changes. I've seen a lot of the programs. One program in particular moved their program from one location to another to outreach and be able to bring in more people and more individuals. They weren't in a population cluster of individuals that they could provide services, recovery-based services to. So it ended in an actual physical move of their program. So people actually are looking at the results and saying, hey, what can we do to better this?
Well, I have one last question for you. I'd like to hear any recommendations you might have for the COSP process going forward. And one thing that I've observed that I would like to recommend is I don't think that the toolkit, the COSP Evidence-based Practice KIT, available from at SAMHSA.gov, is being utilized enough. That toolkit is based on the common ingredients. It's based on the FACIT. So, if you identify an item or a domain, it's really good. That was put together by some of the leading consumer researchers in the United States, based not only on the multi-site results, but on their lived experience. So I would like to see added, for example, to the training manual at the programs, the peer practices component, especially in the toolkit. I think that will really help give some meat around some of those interventions. So, just to close out this webinar, what recommendations do you have?
I think just for our own CQI process, we need to make sure it's got the consistency. That as this process goes forward, that we consistently refer back to our CQI plan, that we're making sure that we're checking in on the things that we're implementing, and that if we're not seeing changes, correcting things or changing things to make the outcomes we want. Because sometimes we tend to have this big flourish around the time of the FACIT, and we do a lot of things, but then as the year progresses, as we get farther from that time, we're not constantly touching base with that. And I think for us, we need to make sure that we're consistently doing the CQI throughout the year, as hard as we do when we get those FACIT scores.
I like hearing that.
Yes.
And one of the recommendations within the CQI model that I shared today was the creation of a team, a quality improvement team, so that it isn't just on the responsibility of the executive director or one individual, because everybody's overworked, but as a team, it's their job to help do that, and to make sure. But as long as you follow the model, you have the plan, the act, the do, the check.
Yeah,
Yes.
absolutely.
Yeah, I would like to see more of those CQI plans have more specific goals and timelines attached to them, so that they are revisited and more in the forefront. So I agree, Sarah.
Yeah, I do too. It's something that's very important, because you get, unfortunately, our funding streams are not very strong.
Robust.
Robust, that's a good word. And we have very few staff. We have some volunteers that we love. We couldn't operate without them. So it's challenging for the staff to take control of this. And sometimes having that team that you have suggested, the CQI team, and having them say, okay, we're going to meet quarterly and check and see where we are. And then giving that report to the director. That empowers the participants to do more. And I think that is such a wonderful idea, to incorporate that, so that the staff who are busy with making sure that everything else is being met is not totally responsible, but is not the sole owner of the program, because we want everyone to take that ownership.
Absolutely.
Well, thank you all for providing your input. Do we have some questions?
Yes, we do actually have a few questions, and as you folks have probably noticed, the chat window alongside on the right side of the video screen there is a good way to submit questions. Pick a couple of these out for you here. Near perfect in the practice of QI might generate confusion and chaos is the comment that leads into this. Can you discuss the difference between the mean and the nature of the golden mean?
Well, from my own perspective, as an artist, the golden mean is used in art is that an understanding of that golden mean allows you to create something that's unique that you can own for yourself, and you realize that you can never achieve because the goal keeps getting greater and greater toward perfection. I mean, I think the exciting thing about life and about our peer culture is it's always changing. It's always challenging, that we're not satisfied with what is, that there's always more you can do and share. At least it's been in my lifetime and probably the lifetime of the panelists here. I mean, it would be nice to get to the aisle of the Plato's aisle where I imagine these values or beliefs in these golden statues floating around. That would be very nice. We could have a golden FACIT, but I like the idea of us working and creating, and I think that the future is malleable.
Absolutely.
Not only the context, but we are the creators of that future. So does anybody else want to add something? Because I use that phrase. I mean, I took it from Obama, and our Constitution that talks about a near perfect nation.
I personally think that that's what keeps us growing. That's what keeps us meeting the needs of our participants, is the fact that we're striving to give the absolute best services possible. But every time you reach a certain level, there is another level to go to, and that's what keeps things good. If we sit back and rest on our laurels and say, well, we're perfect, then that's when things aren't good anymore.
Yeah, it is continuous quality improvement.
Right.
Yeah.
It's not just quality improvement. And when the closer we get to that bar, the more we will continue to raise that bar for ourselves.
In the process of benchmarking, that's exactly what happens, because you're part of the benchmark. So as you improve, the benchmark goes higher as well.
Yes.
Yes.
Do you have another question?
Sure do. The language of mental health is often unique to that culture. How do we deinstitutionalize or show the praxis crossover into the mainstream?
Can you repeat the question, please?
Sure. Starts off with the comment, the language of mental health is often unique to that culture.
Right.
So how do we deinstitutionalize or show the praxis cross over into the mainstream?
For our particular programs, we have a drop-in center and a warm line. We very rarely use what would be considered mental health language. The language of mental health. We don't talk about our diagnoses a lot. We don't do a whole lot of mental health language. And so I think that really helps the deinstitutionalize when someone's involved in our program, to the fact that they don't walk in and we don't say, okay, what's your diagnosis and how long have you been diagnosed? We don't care. And so I think that really helps take that when you take the language away, that's when you deinstitutionalize. Now, if we have to have a common language, but a lot of times we change that common language. Within a consumer-operated service program, it's a different language than what you would consider it in a traditional mental health system.
Well, and I wouldn't describe the traditional mental health system as the mainstream. As we've moved into a recovery-based system, and the results of our COSP Multisite, we have found that it takes both the treatment of illness, which is what the traditional mental health system does. They treat illness, and COSP, which promote wellness. Their main outcome is well-being. It's the treatment of illness plus the promotion of wellness that gets us to recovery. And I would say the mainstream is rapidly becoming recovery-based.
Absolutely.
Yes.
With the expectations listed in the FACIT that we have to adhere and correct, with lack of funding or resources for certain items, how can a COSP survive, and with continued budget cuts?
I can speak almost directly to that.
Me too.
What's one thing that's beautiful about the FACIT is that there are some areas that we might work on, but we might not ever be absolutely perfect in. And we can say, you know what, because of funding and because it's not a huge priority for our membership, we can let that be for a little while. And yeah, our funding streams have gotten smaller and smaller and smaller. But what's beautiful about the FACIT is most of those common ingredients don't take money. They take
culture.
it's a culture shift. It's about the language shift. It's about that recovery shift. That recovery shift didn't take any money. You know, at how we run our support groups doesn't take any money. So yes, funding does affect certain things. We have some accessibility issues that we can't fix because of funding, but we can start an employment group without any funding.
That's very true. That funding is everything. Sometimes, whenever you're evaluating, one thing that we have to remember is this is scientific data that they're gathering. There has to be evidence, and sometimes something so simple as having a sheet for brochures that go out that are distributed to the community, so that we have documentation of that. That doesn't cost but pennies per year. So you have to think in the broad term when you look at these results and how to improve, because you say, well, wait a minute, we did this, and this, but if there's no evidence, there's no proof of it. And so sometimes just taking those little changes and making sure that your evidence is seen can actually affect your outcomes with a FACIT. So I think that's important.
I think one thing that's beneficial too is the fact that we have SCOPE, which is a collaboration of individuals involved in the consumer operated programs, where we can come together and share ideas and help each other if there is something that you're struggling with pertaining to the FACIT. How do I do this with no money? Well, I called this place and they donated stuff. Well, I have one of those right down the street. I never thought of that. So we share ideas and help each other out. And then I'm available for technical assistance also to come in and work directly with programs and provide that on-site, as long as I need to be there, assistance to help them move forward in the areas that they, as Sarah said, as they have identified to move forward.
Overall, all social services are being cut. You think of the dreaded sequester, that it's put a strain on all the services and all the resources within our community. And COSP are really important during this time to pick up the slack, and really COSP have always expanded the capacity to serve amongst our consumer community. There are many people that go to COSP but that don't go to traditional mental health services, and part of our common ingredients that we evaluate the programs are the linkages we have with traditional mental health providers. So we assist in addressing, even as budgets are cut, we're one of the mainstays within the community to provide that help. Also, we're one of the most underfunded of the programs, and I really worked hard to get consumer-operated service programs recognized as an evidence-based practice, because I believe that states would then embrace them and give them a portion of their block grant and be more supportive. And I still hope that process, that will be the future, and I will see that future, because we do set priorities. And if we're talking about costs themselves in terms of budget cuts, which we have suffered as well, is that you also have to look at where money is spent and what the priorities are. And as the promotion of wellness gains equal status with the treatment of illness in terms of a recovery journey, I think that this is the whole concept of the ACA, the Affordable Care Act, is that a sense of well-being among people with psychiatric problems and will enable them to sustain themselves in the community, and that overall can lower costs. That's the whole philosophy of our healthcare reform system, and I think that the FACIT and the consumer-operated programs are very consistent with that, the move to the implementation of the Affordable Care Act.
Yes. One thing I would just like to add on that, we have a long way to go as far as getting block grant funding in some of those areas, but our contracts for the consumer operated programs, the main contracts, were funded at a higher level, at the highest level ever this
Yes.
past contracting period. So DMH did find more money to be able to put into these programs and show that they were important and they did see the validity of them. So
Absolutely.
Yeah, thank
Yes.
you,
We are
because they've
grateful.
been,
Yes.
and
Yeah.
they've been supportive of this whole initiative
yes, very
all
much.
along, and myself, because they have carried a good portion of my contract over the last 7 years to implement this program. So they're really on board with
Highly
that.
invested.
It's kind of a practical extension of this same issue. If one funder expects us to do something that could lower the score on a FACIT, how do we work around that, such as a funder asking for a diagnosis?
That's a very good question. Again, with that, what's nice about the FACIT is you can say, okay, we know we're going to have a lower score in this area because of this funding stream. And as you work through it, you might be working with that funder to change that. But if you can't, it's okay. That's going to be a lower score. You can work on a different lower score and celebrate your successes everywhere. I mean, if you know that that's what's going to be and that's part of you, and there's no way to improve that at this time, then
There's no FACIT overseer. I have the philosophy that every program, this is their FACIT. They need to identify what changes they want to make to improve their program. We've always allowed for unique and creative ways to address things. Some costs are more focused toward treatment, and some are focused more towards socialization. I mean, we have our strengths and we have our weaknesses, but we also have our preferences, what we want our program to look like, our vision of the future. So we don't disdain the use of a diagnosis. We just don't use it to identify individuals. We don't use it in the same way. We may report it as part of information on a survey as far as demographics.
and if we're helping someone link with the traditional mental health system, then a diagnosis is going to have to be talked about. It's not that we don't, that people don't, but they don't have to. And if they have to, then that's the way it is, and that's okay because that's your program, and celebrate the way you do things in your program.
And I would say it's reciprocal in the sense that traditional programs and funders are now being convinced, cajoled, and pushed into adopting a recovery-based wellness approach as well.
Yes.
So there is this give and take.
Right, and so it sounds like, because the people were asking a little bit about using that kind of information in as demographic collections. That's okay?
It is if that's part of your programs, if you need it for funding or if that's part of your program's philosophy. We don't. In our demographics, from our center personally, we do not ask, what is your diagnosis?
On the other hand, we do. And we do this, it's our participant membership form. There's no cost to become a member at Self Help Center, but we do need some background information. And one of the things that has helped us is to modify our programming based on needs of those who are coming into the program. It gives us topics to bring up, such as we found out we have quite a few individuals who have hoarding issues. And so because of that, we had conversations with participants who then said, yes, we really need a hoarding support group. So we found the materials, we started a group, we started a workshop, we took it to the Real Voices, Real Choices Missouri Consumer Conference this year and presented there, and found out there was many people across the state interested. So now it's grown from our demographics into an identified need within our program to an identified need across Missouri. So sometimes having that little bit of information that goes nowhere but into our database for us to review as staff to help those who come into the center. So, I think it's very valid in the way we utilize it.
And that's what makes each program unique.
Yes.
All right. Well, Jean, you want to go to closing comments?
Well, I just had one closing comment here, and I'm quoting Yogi Berra, "The future ain't what it used to be." And I will leave you with that thought to ponder.
Okay, folks, thanks for joining us. Just a quick reminder that if you're interested in purchasing CEUs, that link will stay active on the screen. We'll also send it to you in a follow-up email along with a link to the slides in the PDF format. In answer to a request, also I'll get Jean to email us the link to the SAMHSA kit that you referenced, and we'll send that out in the follow-up email as well. So again, thank you for taking the time to join us. Jean, our fellow panelists, thank you for being here today.
Thank you.